Hello, everyone, and welcome to today's webinar, Path Homeless Outreach and the Opioid Crisis. My name is Zach Stewart, and I am just going to run through a couple quick housekeeping slides before we get started today. So this event is being recorded, and audio is now broadcasting, so everyone should be hearing my voice. We are providing audio via the computer speakers and phone today, but we strongly encourage you to use the computer audio if possible. And please choose just one audio source. If you're hearing my voice through both the phone and the computer, please hang up the phone. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. We are providing captioning for this webinar. Click the link on your screen to access those live captions. We've also provided this link right beneath the slides in the All Questions box, which will be there for the duration of the presentation. Captions will open in a new window or tab that you can position anywhere you like on your screen, and you can adjust the size, color, and speed of the captions. Your line will be muted for the duration of today's presentation, but we do have a couple ways for you to interact with us. The primary is going to be in that All Questions box right underneath the slides there, and you can type your content and your tech questions right into the bar at the bottom of that box and then hit Enter on your Enter key. We will save the content questions for the Q&A portion at the end, and then we will troubleshoot any tech problems you might have right in that box. We also have a couple of status icons which you can use to tell us if you agree, disagree, raise your hand if you need assistance, and those are located right above the slides. It looks like a little person raising their hand. We also have the public chat box, which is located to the right of the slides. Just be careful, anything you type in there is visible to everyone in the room. And we just ask that you keep the conversation in the public chat box relevant to today's presentation. So with that, I'm going to pass things over to today's moderator, Sherry Downing, the Deputy Director of HHRN. Sherry, are you with us?
I am. Thank you, Zach. Welcome, everyone. We are so delighted that you're here today, and we are very excited about the content of this webinar. So to begin, what I would like to do is introduce Thiessen Thomas. Thiessen is the Acting Director of the Division of State and Community Systems Development and the Chief of the State Grants Eastern Branch within the Center for Mental Health Services at SAMHSA. He manages staff who oversee and monitor the mental health block grants, the protection and advocacy for individuals with mental illness grants, the Minority Fellowship Program grants, and several other contracts and grants. Prior to joining the division, Mr. Thomas served as SAMHSA's PATH Program Director, and at this point he's serving as our interim PATH Director. He has more than 25 years of diverse experience in healthcare at local, state, and federal levels, and a master's degree in social work. Mr. Thomas came to SAMHSA after serving in a leadership role at the state level, where he directed statewide initiatives to implement evidence-based practices and programs in the public mental health and substance abuse systems, mental health block grants, and certain Medicaid programs. He also served as a clinical care manager with managed care organizations and worked as a clinician in outpatient, inpatient, and crisis settings. Oh, it's a lot, Thiessen. We're really glad to have you here, so I'm going to hand it over to you.
A co-moderator has joined the conference.
Thank you, Sherry. Thanks for that introduction. And good afternoon for most of you, and good morning for some of you. And welcome, everyone. On behalf of SAMHSA and the PATH program and SAMHSA's Homeless and Housing Resource Network, I thank you for your participation. As Sherry just stated, I previously served as the PATH Director and have returned to lead the project while we are looking for someone to be the PATH Program Director. So for today's webinar, I just wanted to give you a couple of things, being a SAMHSA staff person. So the United States has a serious substance misuse problem. Data shows that America's overdose epidemic is spreading geographically as and increasing across demographic groups. Drug overdoses killed approximately more than 70,000 people in 2018. Nearly two-thirds of these deaths involved a prescription or illicit opioid. Overdose deaths increased in all categories of drugs examined for men and women, people ages 15 and older, all races and ethnicities, and all across urbanization. Tragically, homelessness and addiction go hand in hand. The end result of homelessness is often substance abuse, and substance abuse often contributes to homelessness. The issue of opioid abuse has risen to a level of national crisis as the number of people abusing prescription drugs and heroin has dramatically risen, and the rate of opioid-related overdose deaths has tripled since 2000. No area of the United States is exempt from this epidemic. We all know a friend, a family member, or a loved one devastated by opioids. While the epidemic is notable for affecting people from any race, gender, socioeconomic status, or other identifier, its effects are felt in unique and notably harmful ways by people who are experiencing homelessness. People who are experiencing homelessness and opioid use disorder have significant barriers to treatment. Obstacles include social isolation, lack of mobility or transportation, a fragmented delivery system, and complex treatment needs, including co-occurring disorder conditions. Additionally, the social service needs of individuals experiencing homelessness include like employment and housing, and an increase in the morbidity and mortality of individuals. The PATH program, I believe, has a significant role in assisting individuals experiencing homelessness and a co-occurring substance use disorder, especially with opioid disorders. And I hope this webinar will provide you with some ideas on how to address some of those issues. Again, on behalf of SAMHSA, I welcome all of you. And Sherry, back to you.
Thank you, Thiessen. That was a wonderful and painful reminder of the importance of our content today. So thank you for that. So with that, I would like to introduce all three of our speakers. At this point, I will just tell you, give you their bio so you know who is speaking to you today, and then I will hand it over to our first speaker. So Judy Rice has taught undergraduate and graduate courses at East Tennessee State University since 1996. She has also practiced at a College of Nursing nurse-managed clinic since 1997. Most of those served at this clinic are clients who are dually diagnosed with a mental illness and a substance use disorder and are experiencing homelessness. Dr. Rice has been the primary investigator and program manager for a PATH provider grant since 2000. And prior to her employment at the university, Dr. Rice worked in an inpatient psychiatric hospitalization unit on substance use detox. She's very well published and has made numerous local, regional, national, and international presentations. We'll also be hearing from Melody Pizzolt, who has more than 35 years experience in community rehabilitation with people who have illness and people who have serious mental illness and people who have developmental disabilities. You've heard from Melody many times on HHRM webinars, but she has operated 20 independent grants and contracts in conjunction with direct services to consumers of services for mental health and substance use disorders, in addition to managing the activities of a core mental health funded employment program. Prior to her position at Washington State's Division of Behavioral Health and Recovery, she worked for the Clark County Department of Community Services as the Consumer and Stakeholder Affairs Manager. Ms. Pizzolt brings an understanding of the issues that face people with behavioral health challenges and an overall understanding of the various systems that may be involved in that person's life. Today we also get to hear from Maida Hogan, who is the Community Programs Director at Capital Recovery Center, where she oversees the PATH and Peer Pathfinder outreach programs, the Olympia Bupi Clinic, and IPS supported employment. She has been serving individuals who are experiencing homelessness with serious mental illness in a variety of capacities since 2003. I am delighted to hear from all three of these speakers today. What we hope you'll take away from today's webinar is understanding the benefits of medication-assisted treatment, or MAT. And we hope that at the end of this presentation, you'll be able to describe how one community's efforts to expand homeless outreach while addressing the opiate crisis were effective. I want to encourage you always to check out the SAMHSA website, www.samhsa.gov. There are a tremendous bank of resources for you there, and we know that you'll be able to find many things that help you activate and run your programs. So please do visit. And with that, I'm handing it over to you, Judy Rice. Thank you so much for being with us today.
Oh, thank you. Thank you for the introduction. And I'm so glad to be able to speak to you today about a very important component in the treatment of a devastating illness, and that is opioid use disorder. This illness is sweeping our nation. And what I plan to do today is to briefly discuss some morbidity and mortality statistics related to opioid use disorder. And I will be discussing medication-assisted treatment, and with that comes legislation. I'll briefly discuss that. We will discuss the different medications used in medication-assisted treatment, and we will discuss ways to increase access to these medications for our clients who are experiencing homelessness. And last, we will all be discussing the role of PATH providers in the opioid epidemic. And as PATH providers, I do think you are all on the front line of opiate addiction. The outreach that PATH providers do is such a crucial part of treatment for persons with opioid use disorder and mental illness who are experiencing homelessness. In fact, many studies have shown that having more outreach contacts has been associated with greater numbers of people entering treatment for substance abuse disorder. The opiate addiction and subsequent overdose deaths have reached crisis levels in our nations. Individuals, families, and communities have experienced such devastation from this crisis. For persons experiencing homelessness, the crisis is even more severe. Unfortunately, studies have shown that adults who are homeless are 9 times more likely to die from an opiate overdose than their house counterparts. And that's really a tragedy because opioid use disorder, it is a treatable illness. It is an illness from which people can recover. Unfortunately, there are many barriers to treatment and recovery for those who are experiencing homelessness. And I do think it's imperative for homeless service providers to possess an understanding of how the opiate epidemic is affecting homeless populations and what we can do to better serve this special group of people. And it's also important as homeless service providers that we have the knowledge to explore the advantages and the disadvantages of various treatment options with our clients. So let's take a minute to discuss some statistics about this epidemic that is sweeping our nation right now. Opiates are involved in at least 115 deaths every day in the United States. Every 25 minutes, a baby is born suffering from opiate withdrawal. Nearly 12 million Americans have misused opiates. The highest rates of opiate misuse are among those between the ages of 18 and 25. In fact, 7.3% of Americans in this age group misused opiates in 2018. And it's also important to note that this age group also has the highest rate of heroin use. The next 3 slides are statistics that were released from the CDC in December of last year. And as Tisa mentioned, in 2017 and 2018, there was an increase in overdose deaths. In 2017, there were 17,000 Americans who died from overdoses involving prescription opiates. And an alarming trend can be seen on this slide. If you notice, that there was a sharp increase of drug overdose in those who misuse prescription opiates with other synthetic narcotics like fentanyl. Heroin use has steadily increased in 2006. You will notice the same trend in this slide as was shown in the previous slide. Overdose deaths from heroin with other synthetic narcotics such as fentanyl have significantly increased since 2014. It is important to note the gender differences in overdose deaths. Male overdose rates have steadily increased in the past 4 years, and males are dying from overdoses at much higher rates than females. Overdoses know no boundaries. They do not discriminate. They do occur in urban areas and they occur in rural areas, but they do occur at different rates. In the past 2 years, there has been an interesting trend. There has been a 325% increase of overdose rates in rural areas and a 198% increase in urban areas. And the main reason, as many of you I'm sure can guess, would be limited access to substance abuse treatment in rural areas. 60% of counties in the United States have no prescribers of medications that are used for opioid use disorder. For example, methadone clinics are usually concentrated around states, metropolitan urban centers. And we talked about increasing overdose rates, but I would like to offer some hope. The CDC has released preliminary data that shows overdose deaths looks like they have fallen anywhere between 4 to 5% in 2018, which is certainly a sign for hope. Unfortunately, though, in our state of Tennessee, as the nation's overdose rate fell, our overdose rate increased by 4%. There is a significant treatment gap for those with opioid use disorder. It is estimated that only 21.5% of those with opioid use disorder receive treatment. And that's really sad because there is effective treatment out there. Only 453,000 of the nearly 2 million people with opioid use disorder received specialty treatment in 2016. These are both huge gaps in treatment that we really need to pay attention to. It's important that we have an understanding of the diagnosis of opioid use disorder. Unfortunately, there is a lot of stigma with this disorder, and I think it's important for PATH service providers to educate our clients and especially the community about what this disorder is. Opioid use disorder is a brain disease. It does not occur because someone is weak. It does not occur because someone has a moral failing or has no willpower. It is a neurological disorder of the brain circuitry, a disorder of the brain's reward system, and a disorder of the neurochemistry in the brain. And it's so important that we view this as a health issue. It's estimated that 2.14 million Americans aged 12 years and older meet the diagnostic criteria for opioid use disorder. And according to the DSM-5, that is the Diagnostic and Statistical Manual for Psychiatric Disorders, this book provides us the diagnostic criteria for all psychiatric diagnoses. But to be diagnosed with opioid use disorder, someone would need at least 2 of the following symptoms. Now, I won't waste your time reading the symptoms. I think you all can read these, but they only need 2 of these symptoms present to meet the diagnostic criteria for opioid use disorder. So I'm going to spend some time talking about MAT, medication-assisted treatment. We mentioned that opioid use disorder is a brain disease. Because it is a disease, there are evidence-based biological treatments that can address the brain abnormalities that are present in this disease. One of those evidence-based strategies is medication-assisted treatment. The use of, and what medication-assisted treatment is, according to SAMHSA, it is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. And please pay particular attention to this definition and to the part that says MAT, medication-assisted treatment, is to be used in combination with counseling and behavioral therapies. It is my opinion these medications should never be used alone, that counseling and behavioral therapies are also needed. For medication-assisted treatment, we are essentially, in some of the medications we use in MAT are controlled substances. So there are some significant regulations about prescribing these medications. So let's briefly discuss some of the policy and law related to these medications. The first act to address MAT was the Drug Addiction Treatment Act of 2000. This act permitted physicians to obtain a waiver to treat opiate dependency with Schedule 2, 3, and 5 narcotics. And in order to prescribe narcotics to treat opiate use disorder, they had to apply for a waiver from the government. We call it the Data 2000 waiver, which gives them permission to prescribe this. A more important act came along in 2016 when President Obama signed the Comprehensive Addiction Recovery Act, CARA. One of CARA's most important provisions is the expansion to substance use treatment services and overdose reversal medications. This expansion was accomplished by extending the privilege of prescribing Suboxone in office-based settings to qualifying nurse practitioners and a physician assistant. And essentially, to be able to prescribe medicines used in MAT, physicians are required to complete an 8-hour training. Physician assistants and nurse practitioners are required to complete a 24-hour training before they can be granted the waiver to prescribe these medications. So why do we use MAT? There's certainly a lot of stigma associated with MAT. There's a lot of misconceptions, a lot of misunderstandings. And one thing I commonly hear is where you're just using one drug to replace another drug. And we can combat those views by looking to the research, stating the science. The science shows, without a doubt, that opioid use disorder is a chronic illness. So diabetes is a chronic illness. We treat diabetes with medications and lifestyle changes. We should treat opioid use disorder in the same way. So research has shown that medication-assisted treatment lowers the risk of drug abuse. It lowers the risk of overdose death. It diminishes the effects of physical dependency to opiates, such as withdrawal symptoms and cravings. Clients don't experience the highs and lows. It facilitates engagement in psychosocial interventions. Many of the clinics that provide medication-assisted treatment, one of the requirements is to engage in intensive counseling. And many of the clinics require daily attendance. Their medications are administered every day, and this can be nice for clients when they are early in their recovery. It can be very helpful for them to have this daily structure and to have a place to go every day where they can focus solely on their recovery. Medication-assisted treatment has been shown to decrease criminality. Clients are no longer stealing money to purchase their medications, doctor shopping, engaging in sex trade to obtain narcotics. It lowers healthcare costs. There are better health outcomes associated with MAT. MAT has shown to decrease the rate of chronic illnesses associated with opiate abuse. Studies have shown that persons receiving medication-assisted treatment have significantly lower health costs than those receiving no treatment for opioid use disorder. Medication-assisted treatment has been shown to reduce the risk of transmissible illnesses such as HIV or hepatitis C. It also reduces the risk of IV drug use illnesses such as cellulitis or infections at the injection site. Unfortunately, I have known several clients who have developed severe infection in an arm or a leg, and they had to have it amputated. So what medications do we have in our arsenal to fight opioid use disorder? There are 3 medications that are used in medication-assisted treatment. It's methadone, buprenorphine, and naltrexone. Each medication works in different ways depending on its effects on the opioid receptors in the brain. When someone misuses an opiate, let's say oxycodone, the oxycodone binds to opiate receptors in our brain, which leads to analgesia, pain relief, and euphoria, a high. The medications for MAT work to target the opiate receptors, but without causing the euphoria or high. Irregardless of the differences in the way these medications work, there are common treatment goals. The goals of all 3 medications are to suppress opiate withdrawal, to extinguish cravings from the drug, and to block the intense highs from the drug. We'll start by talking about methadone. Methadone is a Schedule II synthetic opiate. It was developed in the late 1930s, so it's been around a long time. It became FDA approved for heroin addiction in 1972. What does it do? Simply put, it tricks the brain into thinking it is still getting the abused drug. It does this because it has the same action at the opioid receptors in the brain as other opiates do. However, it causes less euphoria and less respiratory depression. The effects of methadone last about 24 hours, so the clients don't have to experience the up and downs that come with opiate misuse. So if someone is using heroin, they shoot up, they're high for a while, then they come crashing down. Methadone, because of its long half-life, hangs around in the system for 24 hours, and with once-a-day dosing, it maintains a constant blood level. And because methadone is filling the opioid receptor, there are fewer places for other opiates to bind. This effect of methadone can block the high if a client takes another opiate, such as oxycodone. There will be no place for the oxycodone to bind to the opiate receptor to produce euphoria. So methadone, again, prevents clients from the significant high of an abused opiate, and it keeps people from experiencing withdrawal symptoms that we all know can cause someone to use again. Who can prescribe methadone? Only licensed physicians with a data waiver. What's more important is what setting can it be prescribed in. Methadone can only be prescribed for opioid use disorders in highly structured OTPs. OTPs are opiate treatment programs that are certified by SAMHSA. So methadone should be only given in a licensed clinic. And the reason for that, why there is so much regulation, is that methadone can be abused. Client requirements. Methadone clinics are usually highly structured and regimented, and they should be. They usually have daily observed dosing in the early stages of recovery with daily counseling. And as mentioned before, daily structure, going someplace, having counseling can be very helpful early on in recovery. Down the road in recovery, clients can earn take-home doses. And seeking treatment is a big step for a client that has opioid use disorder. And requiring a client to wait before treatment can increase the risk of them not entering treatment. So it's very important to tell our clients on the front end there are preliminary steps that must be taken before someone can enter into a methadone program. And some of these preliminary steps involve insurance prior authorization, physical exams, labs. Methadone can cause abnormal cardiac rhythms, so clients do need baseline EKGs. And it's also important to note that methadone does have several drug interactions with psychiatric medications and antivirals for HIV. So this could rule out methadone use for some of our clients. Access issue, methadone could cost anywhere from $12 to $41 per week. In some states, it's not a covered benefit under Medicaid. I think there are approximately 33 states that do allow for Medicaid reimbursement. Some methadone clinics have sliding scale fees. As I mentioned before, methadone clinics are concentrated in urban areas. This can be a concern for our clients. In our state, the state of Tennessee, there are 12 methadone clinics. North Dakota, I think, only has 3. Louisiana only has 10. And there's an excellent resource on SAMHSA's website that can tell you the location of clinics. And if you go to findtreatment.samhsa.gov, it provides a nice resource, a nice map of where treatment centers are located. And before we leave methadone, I will say, there is an abuse potential associated with methadone, and there is an overdose potential. It can cause respiratory depression. Moving on to the next medication, buprenorphine. Buprenorphine, also known as Suboxone, it was FDA approved in our country in 2002. It's interesting to note that France was using buprenorphine in the 1990s in response to the AIDS epidemics in patients who misused heroin. So what does buprenorphine do? It binds to opiate receptors just like methadone does, except it only partially binds to the receptor. So there is less pain-killing effect and less euphoria. But it does bind tightly enough to prevent other opiates, like morphine, for example, from being able to bind to the receptor. Suboxone also significantly reduces the risk of overdose and reduces the risk of withdrawal symptoms. It's different from methadone in that it has a ceiling effect. And what I mean by this is that the opiate effect of buprenorphine increases with each dose increase until a ceiling effect is reached at a moderate dose. When this occurs, no matter how much the doses increase, the opiate effects don't increase. So this lowers the potential of abuse and for respiratory depression. And unlike heroin, the more heroin a person uses, the more euphoria that happens. And then eventually they could get into respiratory depression and stop breathing. Suboxone doesn't pose this risk. Buprenorphine. So who can prescribe buprenorphine? You have to have a waiver from the government. And again, MDs have to complete 8 hours of training, and nurse practitioners and physician's assistants 24 hours of training. Then they can apply for a waiver to prescribe these medications. What setting? This is different than methadone. This can be prescribed in an office-based setting. It can be used as a take-home medication. Some clinics have no required counseling or drug screens. These are not preferable. It's better to refer our clients to centers that provide counseling and to provide drug screens to decrease the risk of diversion. Not too long ago, I had a client who was going to one of our local Suboxone clinics, which has since been closed by the DEA, but the client was prescribed enough Suboxone for 3 people to take in a month, along with Klonopin. She was homeless, and she started selling her Suboxone and her Klonopin and actually made enough to find an apartment and pay for rent. So I think it is important that we, when we are referring our clients to a medication-assisted treatment, that it's a reputable one, and it's a one that provides, treats the person as a whole person, doesn't just prescribe a pill, but also works on counseling life changes. And for clients that go this route, they have to be detoxed or tapered off the opiates before they can start Suboxone. If they are not, they can go into severe withdrawal. Suboxone is more accessible than methadone. Some state Medicaids don't cover Suboxone. Pills, and they come in pill form or in a film that you slide under your tongue, and it could cost anywhere from $60 to $150 a month. Medicare and most private insurance do cover, but again, not all state Medicaid do. And it is important to also consider that there are different forms of Suboxone other than the pills and the sublingual tablets. There is a monthly injection. This is costly. It's about $1,500 a month. And then there is a 6-month implant. And the implant is 4 little rods. You can Google this to see a picture of it. And it's inserted under the skin. The implant lasts for 6 months, and it's pretty costly. The implant is about $5,200. The third medication, naltrexone. This is a very different medication than the previous two in that it is an opiate antagonist, and it is not a controlled substance. It is not a scheduled narcotic. It was FDA approved for opioid use disorder in 1984 and for alcohol use disorder in 1994. It comes in oral form and injection form. And I mentioned it's an opiate antagonist, so it blocks the euphoric effects of opioids, which can prevent craving without producing dependence. So if you take Lortab while on naltrexone, you won't get the euphoria, but you also won't get the pain relief. So if our clients are on naltrexone, pain management is a consideration. I had a client who broke his wrist while on naltrexone. He required surgery, and he could not get pain relief because essentially the pain medicines they were giving him were being blocked by naltrexone. And what I really like about this medication, it does come in pill form, but it comes in injection form. And the injection is given once a month. Unfortunately, the injection is rather costly. It is about $1,200 a month. The tablet form are $36 a month. The tablets come with a lot of side effects, nausea, vomiting, and headache, which is why the injection version is preferred. I have seen this to be hugely successful in my practice with especially alcohol use disorder. And there are drug companies now that will provide this medication free of charge to those who meet income requirements. So I found this to be very helpful that in my clients without insurance, I can sign them up for a prescription assistant program from the makers of naltrexone. The injection is called Vivitrol, and I'm able to give this to them at no cost. And it's important to mention this drug is not used in medication-assisted treatment for the treatment of opioid use disorder, but it is used to reduce overdose effects. And I really think all PATH outreach workers should carry these. Naloxone is an reversing drug. It was approved by the FDA in 1971. And to reduce overdose effects of opiates, it was used in hospitals and by first responders. And it does this it has a stronger affinity to the opioid receptors than opiates such as heroin or oxycodone. So it literally knocks the opiates, the oxycodone, for example, off the receptors for a short time. This allows the person to breathe again and reverse the overdose. But it's important to pay attention that it only lasts for a short time. And because it has a short duration, a client who has been administered naloxone needs to be closely monitored, preferably in an acute care setting. And that is because once the naloxone wears off, the drug that caused the overdose could still be in their system, and they could get into respiratory depression once again. Naloxone comes in a nasal spray or an auto-injection. It is not a controlled substance again. CVS offers it without a prescription in 46 states. It costs anywhere from $20 to $40 per dose, but there are plenty of assistant programs to get it for free. And in 2014, SAMHSA recommended that naloxone should be prescribed with any initial opiate prescription. And I'd like to speak briefly at the end of my portion of the webinar to talk about some things we have done at our place and some recommendations. Medication-assisted treatment, without a doubt, it has saved lives. Again, there's a lot of stigma, a lot of misperceptions. Some of the medications, yes, they can be abused. But research has shown it to be an effective and safe treatment for opioid use disorder. There are many barriers for the homeless in accessing this treatment. It could be the residential instability. It could be they have other basic daily needs, that food and safety are more important at the time. Limited income, lack of transportation, lack of health insurance, all make it difficult to participate in medication-assisted therapy. Cognitive impairments from a comorbid mental illness can reduce the ability to adhere to medication-assisted treatment. But one of the big things, I think, for the clients who are experiencing homelessness is the lack of social support. I can briefly give you two examples. I've had two clients I've worked with. Both were homeless. Both were in the same age. They were in their early 20s. The gentleman who was homeless had opioid use disorder and bipolar. He became homeless. His parents took him in. He went to inpatient detox. He completed medication-assisted therapy within 2 years. He was sober, clean, had independent living, and was working. The female, same age group, came from a very rural area. I actually met her in a jail setting. Her mother started using opiates with her when she was 8 years old. She ended up in jail settings because she was selling opiates in order to support her mother. The nearest treatment facility for her was an hour away. The nearest homeless shelter was an hour away. She truly wanted to change her life, to get off of opiates and to get treatment for her mental illness. But there was no access. It was so sad to look into her face and to see her desire of how much she wanted to leave her life. But she had no support whatsoever to do this. And luckily, we met her in the jail and were able to help her, but it was a long, hard road of recovery for her. So at our clinic, one of the goals for opioid use disorder, especially for homeless, is providing integrated care models. And that is what we do at our place. We have on-site physical and mental health care, so we do provide integrated care. We also focus on, we want to take care of the client's basic needs so they can focus on recovery. So we try to help with food, clothing, shelter, housing, financial assistance so they can focus on the recovery. We do have on-site daily case management and counseling. We provide peer counseling, which is, I think, a very important component to the treatment. We have on-site substance use disorder recovery groups. And then one of the most important components, I think, is frequent and intensive street outreach, and we often will bring a peer counselor along with us. We work hard to coordinate with other agencies. We have a strong presence in the local jails, emergency departments, psych hospitals, and we all know that people with opioid use disorders unfortunately are criminalized for their illness, so we do maintain strong connections with the local jails in order to help our clients. We work hard to find them stable housing. This is a central goal in attaining their treatment goals. And we have an on-site shareable pharmacy, and it's been really wonderful in helping our clients get the medications they need for their mental illness. And those of you PAP providers who work in a city that has a college of pharmacy, it might be worth checking out to see if they have anything similar to this, because it's really been a lifesaver for our clients. And the last slide, what can PATH providers do? I will stop now because I think our other two providers will be discussing this. And I really appreciate the opportunity to talk today about this devastating illness. And I hope if we can help a small bit to help our clients who are homeless and have a mental illness. They are such vulnerable people, such special people who are marginalized and stigmatized way too much. Thank you very much.
All right, thank you so much, Judy. That was wonderful. I am anxious to hear from you, Melody, so I'm handing it right over.
Thanks, Sherry, and thanks, Judy. That was great information. We really appreciate always learning more about the different medications and the different challenges of this brain disease on the impact that opiates have on people's lives and people's physical health issues. So my name is Melody Pazalt. As people heard in the intro earlier, I'm the state PATH contact in Washington State and oversee. We have 14 PATH providers in Washington. And as the health, we're actually located within the Healthcare Authority, but the Division of Behavioral Health and Recovery has really started to do a lot of efforts, as other states have, around addressing the opiate crisis in Washington. And we early on wanted to try and have an impact on people that were homeless experiencing opiate use disorders. And so I'm going to touch on, from the state's perspective, some of our strategies of how we've been using some of the resources that SAMHSA has provided over the last couple of years to try and address that. So, you know, homelessness and mental health issues and homelessness and substance use disorders have been on our radar for a long time, and we have a fantastic data system through our research and data analysis division within the Department of Social and Health Services. And so even back to 2010, they were looking at the homeless population, and so through our integrated client database, they were able to take a look at all of the folks that were receiving Department of Social and Health Services food assistance, cash assistance, medical assistance, and looking at all of those folks and really trying to get a picture of what are the barriers to those DSHS individuals, and really trying to identify what were some of the barriers that people were experiencing around homelessness. And what they found was that 48% of the folks that were compared to all DSHS clients, that a very high percentage of them, almost half of DSHS individuals, had a mental health treatment need. And so, you know, we know that's one of the reasons why PATH exists, is to go and do that outreach and engagement to individuals experiencing suspected mental health issues. But what we also found was that there's such a high percentage of individuals that are homeless that also have substance use treatment needs. And so, but unfortunately, PATH has really been largely focused on individuals with mental health issues or individuals with co-occurring. And so not being able to do homeless outreach if somebody just self-identifies as having a substance use disorder has been somewhat of a barrier to our PATH teams across the state. And as we bring our PATH teams together annually, we've kind of talked about some of these challenges and some of these issues with if somebody just either identifies as having substance use disorders, or the clinicians assessing them only to have substance use disorders, that they would not be eligible for PATH. And so it has been an issue for us over the years. And so our state, as we really try and focus on our PATH teams on homeless outreach, so we're very proud of the fact that the majority of our PATH teams are doing that outreach to individuals that are unsheltered. And so really looking, over 67% of our homeless outreach efforts are folks that are in under bridges, out in the community, living in places that are not meant for human habitation. And so as our homeless outreach teams are out there, they were really encountering a lot of people that were experiencing suspected opiate use disorders. And so we really wanted to see what we could do to try and impact this and expand our homeless outreach efforts. And so when SAMHSA released the state targeted response grants, so we focused a portion of our state targeted response grant to expanding our homeless outreach to individuals with suspected opiate use disorders. We also wanted to look at how we use people with lived experience, SUD peers, and so we have had mental health peers for a long time in the mental health system. It's a Medicaid reimbursable service for many years. And so we wanted to try and say, how could we expand our homeless outreach? We want to pilot SUD peers as part of our service delivery system and potentially get that as a Medicaid reimbursable service in the future. We had to modify our whole peer support curriculum and application process and to be thinking about adding, being prepared to add SUD peer services as a Medicaid reimbursable benefit. We also wanted to have our Peer Pathfinder programs develop stronger relationships with emergency rooms to try and engage individuals with overdose symptoms. And so those were our three main goals of our project within the State Targeted Response Grant. So that was launched in 2017, and we got, pretty sure that was 2017, and so we have 28 SUD peers attached to our 14 PATH teams. So we were really able to bolster our outreach efforts to be able to connect to those individuals that are homeless with suspected opiate use disorders. Maida, my colleague here in Washington, is going to be presenting from a provider's perspective on their work of what it has meant to add more peer to their outreach teams and being able to develop those relationships with emergency rooms to try and engage individuals. I'm very proud to say that we have just really increased the number of outreach individuals, and so this is our Peer Pathfinder teams, those 28 staff that are doing outreach. So we really have kind of a parallel path program called the Peer Pathfinder program. So we're out doing homeless outreach, and so we've connected with over 1,400 individuals, and you see some demographics. And then our goal is to get people connected to treatment, to get them connected to medication-assisted treatment, to get them connected to housing and other resources. We also were able to achieve, through the lessons learned, able to add SUD peer services as a Medicaid benefit that went into effect this summer, and so we're very pleased that we have now been able to go live with having our SUD peer services be reimbursed within treatment agencies, and so we hope that we'll continue to have SUD peers within those OTBs, OTNs, and other outpatient service delivery systems. So we're very excited to that. So we've been able to expand our homeless outreach as well as create a Medicaid reimbursable benefit. We continue to develop those relationships with emergency rooms. That's a continual challenge, and what that looks like in terms of having the relationship of our outpatient providers, our homeless outreach teams, and those relationships with the emergency rooms continues to be a challenge, but we're going to hear from Maida on what some of their successes have been here in the Olympia area on that relationship. So I will turn it back over to Maida unless Sherry, you want to step in. Otherwise, I'll let Maida go ahead and get started.
No, we'll hand it right to Maida. Welcome, Maida.
Thank you, Sherry, and thanks, Melody, and especially thank you to Judy for that thorough yet concise overview of medication-assisted treatment. I don't think I've ever seen it addressed so thoroughly and so concisely. I was definitely taking notes about how to do that. So I'm the Community Programs Director at Capital Recovery Center. I oversee our PATH and Peer Pathfinder outreach programs, our supported employment program, and the administrative side of our Olympia View Clinic, which is our low-barrier Suboxone clinic. The Capital Recovery Center is a peer-run community mental health agency in Olympia that serves Thurston and Mason counties. We started as a clubhouse model in the 1980s. So our organizational culture is very peer-oriented and recovery-focused. The vibe is really relaxed and familial. When you're in the building, it feels like not so much like service delivery, but more like sort of friends helping support each other. And we have a trauma-informed approach to staffing, so we're fairly relaxed about how we work with each other and about how we design, how we manage our staff, because they are all peers. So it's kind of a perfect fit for trying out what substance use disorder peer outreach can look like. We have the existing peer counseling program, which has been around since we became a community mental health agency several years ago. We have our mental health outreach through the PATH program, and we have the county syringe exchange operates out of our building as well. So it was kind of also adding that in, it was kind of perfect for this opiate use disorder outreach program to come in and be able to get referrals through the syringe exchange, as well as to work with them to help design the Olympia View Clinic, which came along later. Our outreach workers participate actively in coordinated entry through the Vulnerability Index team. We have strong working relationships with other outreach programs because our PATH program has been operating in the community for several years and developing those relationships. So when we're working with folks and we're going out and doing outreach and connecting with folks and developing rapport, we're bringing them in, connecting them to services. It feels like kind of an in-network referral. So in most cases, it's actually better than a warm handoff. It's, you know, here's what the process looks like for getting signed up for housing. Here's the guy you need to talk to. He's there during these hours. Let me walk you over there. So we have all of that already in place. And then the Peer Pathfinder program comes along a couple of years ago, and we're basically just ripe for it. And our PATH outreach workers have identified that there is a population that they haven't been able to serve. So people without serious mental illness who do have a substance use disorder, who aren't appropriate for PATH, but need to have the same kind of intensive outreach and navigation services provided to them. So we've identified sort of the shape of the whole in our services, and then along comes the Peer Pathfinder program, which is a perfect fit for that. And we were able to pair those new SUD peers with our existing PATH outreach program and have them shadow. They were able to jump right in, figure out how to do outreach, and the Capital Recovery Center was already, because of the PATH program, already adapted to serve a high turnover population with complex needs. So it was really just a perfect fit from the beginning. We did notice, however, some differences. So there's some overlap between, there's some overlap between the population that PATH serves, which is homeless folks with serious mental illness, and the population that Peer Pathfinder serves, which is people with opiate use disorder who are homeless. We were definitely encountering folks with opiate use disorder in our PATH outreach, but when we brought on the substance use disorder peers, we noticed that there are some fairly subtle differences in terms of how we would want to do outreach. So people with serious mental illness would tend to be more highly visible. They would tend to be more concentrated in the urban areas. They would tend to be maybe already somewhat accessing services, but sporadically. Whereas the people that we encountered with opiate use disorder were maybe a little bit harder to reach. Maybe they had places they would go to that were a little bit out of the way. So they were more likely to be sort of at the edges of town, you know, not as visible. And we also noticed that we needed different outreach supplies. So this seems really basic, but you know, everyone can use shampoo and snack bars, and so we were always carrying those, and clean socks, and other, basic staples of outreach. But when we brought on the peer pathfinders, we discovered that it was really helpful to have wound care kits, naloxone, fentanyl test strips, things like that, that we decided, okay, well, we're going to have to start stocking those and sending those out with the outreach teams on a regular basis. Capital Recovery Center historically has a mental health focus. So some of the staff are peer recovery coaches, but most of them have a pretty solid background in doing mental health peer counseling. So there's maybe a limited understanding of non-abstinence-based substance use disorder treatment. That was a bit of a challenge, the same way that it is with the wider community, where there's just a learning curve, a lack of understanding about what substance use disorder is, what harm reduction looks like, what medication-assisted treatment is, especially. That's pretty new to almost everyone. And it tends to feel like it's just the molasses that we swim in. It's just that's out there, and it's something that we have to educate people about every step of the way. So within the organization, there was a little bit of that. But being a recovery-oriented organization, people were pretty quick to pick it up, so we were lucky in that way. Also with the mental health focus, because we're a mental health agency, and I'll touch on this a little bit later, but it ends up being a challenge. I know Melody mentioned that substance use disorder peers are Medicaid billable now, but that's only true if you're chemical dependency treatment. So we don't have a CDP on staff, so we actually can't bill for our SCD peers because we're mental health and medical only. So initially when we started, we were going out and identifying folks with opiate use disorder, and we had our peer pathfinders, and they were all geared up to go do outreach, and they're identifying people, and they're developing that rapport, and then they're going to connect them with medication-assisted treatment. And really, locally, we didn't have much of anything. There was practically no access to buprenorphine and very limited access to methadone at our local treatment providers. So our peer pathfinders were sending clients to 30-day inpatient treatment or intensive outpatient, which for some of them, just, if somebody's homeless, going to treatment 3 times a week can be a real hassle with figuring out transportation, and, if somebody's trying to get a job, then their schedule is limited. And so it was a huge barrier for people to get treatment. We also, so the program is designed to embed in the emergency department, and we initially met with Providence St. Peter's Emergency Department and started working with them about how we could connect folks who come in with overdoses or other opioid use disorder related issues, how we could connect them with treatment and with our outreach services. And what they were really needing was for someone to respond at 3 a.m. And we simply didn't have the staffing levels to provide 24/7 coverage, and they didn't have the space to even bring somebody in. So when we were talking about, well, we could take one of our peers and just have them, sit in the emergency department and connect with folks as they come through, they said we just don't have the square footage for that. So we presented to their staff about the Peer Pathfinder program, and we set up a memorandum of understanding to receive referrals, and it kind of just stalled there. We didn't really have a way forward with that. So looking forward, I'm going to go over a few of the things that are happening locally to address the opioid crisis and the ways that our peer pathfinders are involved in that. They've actually been instrumental in, we have an effort called the Greater Regional Outreach Workers League, aka GROWL, and the peer pathfinders were actually instrumental in convening this and have taken a leadership role in coordinating with other outreach workers. It was formed earlier this year with the goal of reaching people outside the downtown Olympia core, so going out into, if you're familiar with the geography of the area, going out into sort of the suburban areas, and then we have some smaller towns out in the rural areas that don't get reached as often, and definitely Mason County gets neglected because it's fairly rural and hard to do outreach to. So we're coordinating all of that with city and county staff and outreach workers from at least 6 other agencies, having regular coordination meetings and conducting joint outreach activities, and have actually established a presence out in Yelm and then in Shelton as well, and beginning to get folks in those communities connected with services, which is historically has been a challenge, and it's been really cool to watch the peer pathfinders take that on and really get that moving forward. Our relationship with the emergency department, after our initially bumpy start, we now have what we're calling a peer warm line, which is from 9 a.m. until 8 p.m. We have a number that emergency department staff can call. And for now, it's looking like maybe a half-hour turnaround for a peer to return the call and connect with the patient. But in the long run, we would like for it to be actually a hotline that's being answered immediately and for it to move to 24/7. We also are working with emergency department staff to develop protocols to start inducting people on buprenorphine in the emergency room so that somebody can come in with an overdose and they can immediately start them on buprenorphine, give them a couple of days, and then send them over to our clinic so that we can continue them on bup. We were awarded treatment sales tax funding earlier this year, and we were able to fund a justice outreach position to reach folks with opiate use disorder who are justice involved. So folks who are either currently incarcerated, recently released, on probation, or in an alternative court arrangement like drug court. So this individual is going and doing educational presentations in the county jail for folks who are in there who might have opiate use disorder or who might just want to learn more about medication-assisted treatment, and educating them about it, and then making sure that upon release that they have an option to connect with the Olympia Bupe Clinic. We also, our peer pathfinders were actually played a huge role in starting the Olympia Bupe Clinic, which sort of became more than an idea late last year. We were able to get additionally state opioid response funding for that, and it really kind of came out of the Peer Pathfinder program, identifying this unmet need for medication-assisted treatment in the community. And then we were fortunate that there was another group of folks in the community who were sort of looking at what would it look like to offer low-barrier access to buprenorphine. And when we brought it together, we said, well, Capital Recovery Center might be the perfect location to do that, and we already have outreach to bring folks in and to get them to that service. So the Olympia Bupe Clinic applied for the SOR funding. We serve 5 counties with our opioid treatment network. We have over 10 formal and informal referral partners. This is really the big deal outcome of the Peer Pathfinder program. We were able to take a couple of our Peer Pathfinder staff and incorporate them into the design and implementation of this clinic. So it's not just we have peers that work in the clinic. It's the whole thing was actually designed by peers to be low barrier, to meet people where they're at, and to really give people the service that they need when it comes to medication-assisted treatment. So one of my favorite stories is actually one of the lead peer recovery specialists in the clinic was a peer pathfinder until we opened the clinic, and she transitioned over. But before that was actually a peer pathfinder client, and I'm not going to tear up on the webinar, but it was, we got to watch her. So she actually, last summer after she came on staff, found out that she was pregnant and was really concerned about being on buprenorphine and being pregnant and what does that all mean, and did a bunch of research and talked to a lot of people about it, self-advocated really powerfully with her own medical providers, and was able to come out of that with a good chunk of experience about how to work with folks who are dealing with pregnancy and parenting and opioid use disorder and medication-assisted treatment. And she's just been an invaluable asset in the clinic, and one of our golden stories. So yeah, the Olympia Bupe Clinic is really a big deal. In the future, I think we're going to need to look at more ongoing and long-term low-barrier medication-assisted treatment. So we're doing a lot of, the Bupe Clinic is doing a lot of inducting folks who are sort of at risk. They're homeless, or they're justice involved, or they're pregnant and parenting, or maybe they have a co-occurring mental health disorder. but they're folks who might have difficulty engaging with traditional treatment models. So it's really just folks come in and they get medication the same day, and we just meet people where they're at. We're not looking at, they don't need to participate right up front with the psychosocial supports. They get to choose how they want to engage with that. We've actually found that people are much more likely to engage enthusiastically with those supports once they've started the medication. So we're putting people in the driver's seat of their recovery so we can provide the medication without a requirement to participate in any additional services, and then let folks choose what they want to bring in. But what we're having trouble with is when we got people up to the 2-week limit on their prescription, where can we send them out to? We've served 600 people since January, and there aren't a lot of ongoing MAT services that are low barrier enough to meet folks where they're at. So we have people with polysubstance use. We have people who are maybe occasionally relapsing, or people whose schedules don't allow them to go in every day for dosing or to meet some of the other requirements of these traditional treatment providers. So that's one need that we've identified for the future. We also are going to struggle with Medicaid billing for our SUD peers because we're not a chemical dependency treatment service. So we're going to need to look at alternative funding for those positions. We have currently 2 SUD peers who are working in the clinic who should be Medicaid billable, but we would need to get a chemical dependency professional. And then another thing that we're looking at is, what about methamphetamine? We've got a lot of folks who are either dually using opioids and methamphetamines, and when their opioid use disorder is treated, they've maybe cut back a little bit on meth, but they're still not able to access other services because of their meth use. And there's not really a silver bullet for meth the same way that there is for opioids with medication-assisted treatment. So those people are still struggling, and it kind of feels like that might be the next challenge for all of us. But I don't know, I'll leave that up to the policymakers. So that's what I've got.
Wow, that was amazing. Thank you so much. I am delighted with all 3 presentations, and Maida, thank you. That was great. And I also would like to compliment you on your choice of hat. It's fabulous. It made me laugh when I first saw the picture, so thank you for that as well. So we're going to bring all three of our presenters on now, and I would just invite you to share your questions in the box. This was really wonderful information, and I agree, succinct and useful, and a real problem in our communities, as Tisa mentioned earlier, and as we're all seeing. We're all seeing this devastating effect of these drugs on our communities. So questions. I guess one of my first questions really would be, is there, you brought up the methamphetamines, and I know I live in Montana, and we're seeing the opioids definitely. We're also still seeing the devastating effects of the methamphetamines. Is there a huge difference in the way that you practice outreach and engagement with somebody who's on the opioids versus the methamphetamines? And maybe that's a naive question, but I think as past providers, that's certainly certainly something I would like to know. And I'm happy with whoever would like to start that. Judy, we haven't heard from you lately. Would you like to start that and then maybe hand it over to the others?
Sure. We in East Tennessee are certainly struggling with meth. It's a huge, huge health concern in our issue. We are probably at our clinic or our day center seeing more issues with meth than we are opiates at present. And I don't think at our place, I don't think we have a different approach as far as our outreach goes, it is very challenging if they have an opioid use disorder, because when if they're in medication-assisted treatment and they're positive for meth, they're kicked out of treatment. So that certainly creates a lot of challenges for this group of clients.
Absolutely. Melody, what are you seeing in Washington? And then we'll hand it over to Maida.
I think we're definitely, seeing, actually we are seeing some decline in the opiate overdose deaths, but also an increase in meth. So it is, as Maida said, it's still a challenge, and there isn't a silver bullet. And it's not to say that medication-assisted treatment is a silver bullet, but it certainly has changed the trajectory. It has moved the needle in terms of trying to reduce the deaths amongst individuals with opiate use disorders. And so, unfortunately, there isn't that tool in the toolbox like there is for OUD with meth. So it's going to continue to be a huge challenge for communities. And I don't think that we change how we address our outreach. I think we still continue to do engagement. I think the challenge is having the resources to do outreach with individuals that self-identify as only having substance use disorders and not having that mental health. I mean, we certainly know that there's a very high prevalence of mental health issues amongst, but if people don't self-identify as having those challenges, then we can't necessarily enroll them in PATH programs. And so it's how to have more outreach resources to address the substance use population.
Absolutely. Thank you. Maida, what would you add?
I definitely agree with Melody that, people are people and they need kind of the same things. One thing that our outreach teams have noticed is that there are geographic differences. People are sort of self-sorting, at least in our area, where it's, over sort of on the east side of town is what's been identified as sort of the speedy area. So if we were going to develop a program to do outreach to folks who have issues with meth, we would definitely be sending our outreach teams out there on a regular basis, whereas the west side is a little bit more the opiate use camps. And people are definitely just deciding where they want to be based on who they want to be around. And so, but that's, it's interesting. I don't know if it would definitely affect our outreach strategy that much. I might speculate that hours would be a difference, that you might go out different hours to find different people who are using different substances. But yeah, I think the thing is we really need to figure out what effective treatment for methamphetamines looks like. And there are some promising approaches, but we're definitely not at the medication-assisted treatment level yet, which is, as an outreach provider, that's what I would like to see. Like if we go out and make that connection with people, where can we plug them in at that we can say, here, this is what's going to work for you if you're ready.
Absolutely. It is a tough one. And then, of course, we still have, significant alcohol abuse and other drugs as well. So it's complicated. I wish there was a silver bullet for the methamphetamine. It's really having a resurgence here in Montana, I know. One thing that I would like to talk about a little bit, so people leave this webinar and they're going to go forward. Can you share some tips? I know that this is one of the slides that was in Judy's deck and she let it go, but I would just like to talk a little bit about what can PATH providers do? So relative to this issue and to dealing with opioid-involved PATH clients, what can the PATH providers do? What are the top 4 things that each of you would recommend? And Judy, you clearly, that'd be great. Thank you.
I think it's really important that we provide a choice of recovery paths for our clients. So, treatment isn't one size fits all. So I do think it's important to be aware of the most effective treatments. so we can provide our clients with different choices so they can pick what is best for them. And I think harm reduction is really important. I think it supports respecting the person and their experience, especially those who are living with homelessness. And I know that's something I struggled with early on in my career, but now I realize if they could just take one less pill a day, that's a huge thing. Well, my client I'm working with now that drinks a gallon of liquor a day, if he could just cut down to half a gallon, that would be great. So I think harm reduction is important, and working with the client to remove barriers to treatment, whether it's helping them fill out a prescription assistant application for medication. So I think it's important to know resources, how we can help them with the financial end of treatment.
Thank you. So, Melody, what would you like PATH providers to go forward? What are the 3 or 4 tips that you would hope that they'd carry out of this webinar?
Well, so in Washington, a lot of our community mental health agencies are also duly licensed community behavioral health substance use treatment agencies as well. And so, just making sure that they're both working on behalf of those individuals. And so, developing relationships with the emergency rooms and looking at adding SUD peers as to their book of business, looking to see how we can, educate staff on the different, on methadone, buprenorphine, and naltrexone. Just I think a lot of education of staff. I think that's great. Just the more we can educate people, the visibility, the awareness. So I think it's really, it's all of these things, and just really becoming better educated. If we're really going to move to integrated whole person care, we can't have all of these different systems that we need to treat the whole person, the same one person, and looking at really just that whole person and not trying to dissect them from substance use go over here, mental health go over here, primary care go over here. It really is one person, and we should be thinking as one system.
I love that. Thank you. Maida, what would you add? What would you hope that PATH providers would go forward from this webinar?
I would say that PATH providers and frontline outreach staff are ideally positioned to identify emerging trends and to document what's going on out there. I mean, these are the people who are meeting folks where they're at. They're going out into the community to places that other people don't go to. They're having conversations with these folks that other people aren't having. And they're really well positioned to gather information about what are the needs, like what are the sort of nuances of services that aren't happening, what are the things that nobody has even identified as an emerging need, and to be able to document those and to document the scope of it. We went out this week and we ran into 12 people who were having this issue and not able to access services for it, and to be able to bring that to people who design programs, people who write policy, people who make decisions, and to be able to make sure that those services are available for folks.
Thank you. Absolutely. So I just have one more question, because that's about, we could keep this going all afternoon, but we've really only got about 4 minutes left. But one of the things that I've been thinking about a lot lately is that there have been tons of resources poured into the opiate crisis from federal levels, all kinds of agencies, including SAMHSA, for the last little minute. So how do we sustain these services? These problems aren't going to go away even when sort of the flood of resources does. So what are some of the suggestions that you have for sustaining the services that we've begun implementing under, sort of as we've addressed a crisis? Melody, you're really good at this, so maybe you could start.
I think we need to look and see, what are the interventions that are happening under, the investments from SAMHSA, the state opiate response grants, and where, what can be folded into, Medicaid service delivery system. I know that, CMS is also looking at, I think that there's, the challenges around doctors getting the, being able to prescribe Suboxone and getting that policy of only being able to prescribe a certain number to a certain number. And so, can we look at some of the policy issues that perhaps this, policy issues around how doctors prescribe opiates. I know in Washington State we're looking at how dentists prescribe opiates after somebody's had their wisdom teeth filled, and we've invested in a prescription drug monitoring program. And so some of that is starting to change how opiates are prescribed, how they're monitored, how doctors can actually add the medication-assisted treatment to their being able to prescribe it. So I think that there's a lot of policy issues. I think in terms of some of the interventions, again, particularly for homeless outreach, I think we're drawing more attention to the fact that certainly people that are homeless also have mental health and substance use issues, and that investment in getting people engaged out in the community is important in getting them into treatment, using effective practices such as having people with lived experience as part of that homeless outreach team. And so how do we then sustain those challenges? And we're continuing to try and look at that. But then once they're in treatment, adding SUD peers or peers to your book of business, I think, are also really effective strategies.
Those are wonderful. Those are wonderful ideas. Thank you. Judith, have you given any thought to this? How do we sustain these efforts even after sort of a flood of federal resources eventually disappears? I don't see any sign of it yet, but it seems to be the way it goes.
Well, I know at our center, we're always looking for grants. We do a lot of community presentations, we've had wonderful support from the community, so much that we're able to have a fund, and they donate money, and we keep the money in an account. We have a local pharmacy, it's not a chain pharmacy, that works with us to give us medications at the lowest rate. So that's a small help, but in terms of access to the previous statement that was made by Meta, I think more physicians and nurse practitioners need to be able to prescribe the medications. And I have the statistic. As of September 2018, there were only 44,000 physicians and 8,000 nurse practitioners and physician assistants who were approved by the government to prescribe Suboxone. And we all know there are many more physicians and nurse practitioners and physician assistants than that.
Holy cow, that's an interesting statistic. Good, great points. Maida, anything you'd like to add to that?
I think it's maybe a little bit radical, but I think if we're designing programs in a way that's recovery oriented, and we're empowering the people who come through those programs, and we're employing peers in delivering these services, I think what we're doing is we're working toward building communities that can be more resilient, where we can actually go upstream and reduce ACEs, where we can, look at what does recovery actually look like for the holistically, not just in terms of not using the drug, but in terms of being employed at something that you love, having a house that you can be proud of, having social networks that are supportive and resilient. I think if we design our programs toward that, and I think we might see less need for this kind of service in the future.
Beautifully stated. Wonderful. Oh, this was terrific. I'm going to thank everyone for coming on behalf of SAMHSA, and I am going to hand it back over to Zach to close us out. Thank you, everyone, so much for your wonderful presentations.